Welcome to Health and Human Services, and I know that the House is in session today, and they've got a lot going on, so without any further ado, I'll open the hearing on House Bill 66, establishing a committee to study non-pharmacological treatment options for patients with chronic pain. And is there anyone here to present? Okay, come on down. Welcome.
Thank you, Ms. Chairman. Good morning. In addition to being a representative, I'm Dr. David Nagel. I've been a physician here in Concord, New Hampshire for about 30 years. I treat people with complex disabilities with a focus on pain management. That's part of my job. My more important job is I've been advocating for the rights of people with complex disabilities for that period of time too. As part of what I've done, we've done a variety of things, including something that Senator Bradley would be interested in. About 25 years ago, we created the Acupuncture Practice Act together, which I think was a really good thing. I was also involved in initiating and writing all the opioid prescribing rules in this state. What's the most important thing to me, though, is that in terms of managing complex disabilities, especially pain, is providing access to comprehensive integrative care. When you look at, I think most of you are somewhat aware that we have a thing called an opioid crisis in this country, and it's been very easy to blame certain people for that. I know we like to blame Big Pharma, but I think the problem's a lot more complicated in the sense that we basically pay for pills and procedures and then get surprised when all patients get our pills and procedures. It's been our belief in the pain management community for over 30 years, back to the mid 80s, that we know that comprehensive integrative care works. And what that means is that we provide services from a wide variety of platforms, including medical things, and non-medical things, allopathic and non-allopathic. So for example, acupuncture, chiropractic, massage, all sorts of things like that. And we believe that all things have a place and they should work together integratively. 30 years ago, a couple of us created a community-based integrative pain program in this city that worked incredibly well and reimbursed very poorly. And before you know it, we didn't have a place because we didn't generate revenue. And that was a bad thing. The good news is that over the years, the VA has looked at this issue, the state of Vermont has looked at this issue, and they've created models of care that work and they're cost effective. But the minor problem is this is not the VA and this is not Vermont. Their systems are very different. So what we would like to do is to use the models that we've created to put together a committee. Gary Merchant and I wrote this bill together. The first part of that bill I wrote, because that's really important to me, is to generate the framework of why we're talking about this. But we believe that when we bring people together of various backgrounds in a group together, no matter our background, to try to figure out to problem solve together is how we can make this thing work in New Hampshire. You're going to hear from folks from the acupuncture groups today. You're going to hear folks from the chiropractic group today. We believe that massage is important, and we believe that psych is important. Cognitive behavioral therapies and other mind-body therapies are important. What's also important to the insurers are extremely important in this model, and they're here also. So everybody's here, and we all think that this is important. We also believe that the people providing these services, at this point, should be licensed so that there's some level of oversight. There's a lot of other therapies out there that we're not sure about reimbursement yet. We need to figure out models for that, but that's not going to be part of this initial phase. The goal is to bring us together, develop a pilot program that we think can work in New Hampshire, and then do our best to make that work. Just a couple of other notes. I've been working on this level, the national level, for a long time. The CDC has created 2 guidelines on pain care policy, and I was involved in both of those. The National Pain Strategy looked at this exact same thing, from how do we provide services, how do we prevent pain, how do we bring together the best literature in the country to do this, and I was involved in that. The Department of Health and Human Services at the federal level put together 13 different agencies to do kind of what we want to do. And unfortunately, nothing's come out of that. So it's time for New Hampshire to do something, to step up. And I think based on a number of the bills that we've been able to pass, we can be first in the nation and develop models of care that can be very effective for other people. Last thing, I'm also the pain management chair for the NFL. I designed the pain care policy for the NFL, and the model of care that we created for players mimics what we really would like to do in this state, is to emphasize restorative care, empowering people with the ability to manage their own pain. Because right now we don't do that. We force them into systems that give them no control. And that's the worst thing you can do to somebody in pain, is make them dependent on somebody else. We want to enable people with the power to choose what they need to do to help themselves. And I think I'll leave it at that. I'll be happy to take any questions.
Any questions from the committee? Senator Abar.
Is laser therapy included?
Yeah, so if you want, in the testimony I gave you, there's the website, the link for the NFL guides there. If you go to the NFL guide, make sure you click on the PDF, not the main format, the pretty one. Look at the PDF. And what we did on purpose, because I personally believe that restorative models that give you the power to manage your own pain are the most important. Exercise, things like that. But Graham Lauriston, he's a PT from Australia. He designed the PT element. I designed all the philosophy, the medical elements, things like that. But he has laser therapies in there. They do have value. Is that part of our bill? No, because they're available now. So and in fact, PT is really not even part of this bill because it's reimbursed now. What we're looking at is empowering people that aren't included in the current system right now, things that we think that are really important for every patient. And since you brought that up, every patient's unique. You know, what works for me won't work for you, won't work for you, won't work for you. So what we need to do is provide patient-centered care, and you need to have a broad variety of options available for each individual. So, and you need to have all of those available, and that's our goal, because right now it's not happening.
Any other questions? Seeing none, thank you.
Thank you.
I have one last speaker, and that's Leah Stagnon. Welcome.
Good morning, Chair Birdsall, members of the committee. My name is Leah Stagnon. I work as the association manager at the New Hampshire Chiropractic Association. And I'm just here this morning urging you to support HB 66. Our feeling is that our current healthcare system is built quite effectively to serve those with acute medical conditions, but still really inadequately considers those with chronic pain-related conditions. And something that I hear frequently from our members and from chiropractors throughout the state is that while most commercial insurance policies do cover chiropractic in some capacity, there's still a lot of barriers to access. There's a significant lack of uniformity between plans. There are a lot of plans still offering an inadequate coverage of non-pharmacologic pain management services to really fully manage a chronic diagnosis. And unfortunately, without access to high quality multimodal pain care, opioid pain management often becomes the default option, and avoidable disability leads to less granite staters in the workplace. And I know that for long before I got involved, members of the NHCA were coming up to the legislature and testifying on this and trying to make changes. And you know, every year we're asked, is there evidence to support this? And there is a lot of evidence out there. And so we really feel that for the sake of our members' patience. It's time for stakeholders to convene and really thoroughly review that evidence that is out there, to assess whether our current policy is congruent with their modern understanding of chronic pain, and to make possible policy recommendations based on the committee's findings. And we really think that through this process that the committee will find compelling evidence for improved access to non-pharmacologic pain management services. And that will lead to reduced escalated care, reduced opioid use, more granite staters in the workforce. What I really appreciate about this committee, and we are very excited to hopefully participate in this as an association. As someone who lives with chronic pain, I love that patients are included in this as well. I think that those voices really need to be at the forefront in shaping our policy. And I'll stop there if anyone has any questions.
Thank you. Any questions from the committee? Seeing none? Thank you, Leah. I have a number of people signed up, but none of them to speak. Is there anyone here that would like to speak on House Bill 66 that wasn't given the opportunity? With that, I will close the hearing on House Bill 66. And Cam, when you're ready. Oh, sorry. Okay, I am going to open the hearing on House Bill 188, and the speaker is Daniel Popovici Mueller. Welcome.
Thank you, Thank you, Madam Chairman and members of the committee. I appreciate the opportunity to introduce the bill. I want to apologize ahead of time. My time here may be cut short because there is a critical vote on the floor that may require me to stand up rather suddenly and walk. I apologize in advance if that happens. But it's another incentive to keep this short. And fortunately, this is a very, very simple bill in the language. All it does, it removes a tiny paragraph from statute that limits the ability of patients to sometimes get the care they need. And I just want to say, even though I'm sure the committee is aware of it, that this bill ended up on the consent calendar with a unanimous recommendation from the House committee. And in a nutshell, the concern raised by the existing statute is that sometimes patients may find themselves unable to receive physical therapy because of that requirement to get a physician referral if there is no documented improvement after 25 days of therapy. Fact is, there are certain types of injuries where you won't get an improvement in the 25 days. I mean, I had a torn Achilles, and trust me, 9 months of physical therapy is nothing fun. And I definitely did not get a measurable improvement in my first 25 days because that's a very, very long-term process.
Just like being a member of the legislature, right?
I wouldn't know. I'm a first-term representative. For now, it's all roses.
All right.
Yeah, I know. But seriously speaking, there are patients who don't have health insurance, for whom the cost of seeing a physical therapist is a lot, and now we put an additional burden of seeing a physician on them just because there is no documented improvement in 25 calendar days. Also, it takes time to see a physician. Not everybody can set an appointment at the day that's convenient for them. Even if they have the ability to pay for the visit, they may have to wait for weeks until their primary care provider sees them delaying the therapy. And most importantly, because there is a legitimate concern over every industry having bad actors and the possibility that physical therapists, certain of them may, provide services that are not needed. This is already taken care of in the remaining statute. There is already a legal obligation for the physical therapist to refer the patient as needed to a doctor if there is clear indication that that's needed. And also, we already have, the regulatory bodies, the licensing boards that can handle any, complaints on that matter. The training of the therapists has greatly improved in the last decade or so, which is the last time I think this bill has been in front of the House and Senate. And everybody that testified agreed that this is a very necessary and welcome bill. It's a minor change, but it's a change that will have positive impacts, and there are no real downsides to removing this statute. I appreciate you taking the time, and I'm obviously happy to take any questions.
Any questions from the committee? Seeing none? Thank
Thank you very
Dan.
much.
I see no one else who would like to speak. I have Paula Minahan supporting, but absolutely, come on. Just for the record, introduce yourself.
Yes, this is Dr. David, or Representative David Nagel. This bill really dovetails well with 66. My specialty is, again, physical medicine rehabilitation. What I love about my job is I get to work with people from all different backgrounds. I work with physical therapists for over 35 years. You come to respect their abilities. As you all know, I hope that PTs now have to have a doctorate. And I will also state, from having worked with doctors for longer than 35 years, is most of us really don't have a clue what a physical therapist actually does. So it seems odd that a physician's able to control what they do when they know better what they do. As was stated, it's really important to give them more control, and the folks that I work with in Australia, they don't need a doctor's referral to do PT. And what that's allowed them to do is become the most creative, best physical therapists in the world. And if you talk to the PT community, they will say that's where the best PTs come from, and that's why. So I think that this bill provides us with an ability to help improve the creativity and take advantage of the abilities of physical therapists in our community. And I think it's really important, and I endorse it strongly. I'd be happy to take any questions.
Any questions? Seeing none? Thank you, Doc. Anyone else that would like to speak on House Bill 188 that was not given the opportunity? With that, I will close the hearing on 188. And we have 7 minutes.
I'll move to go into
Second?
All those in favor of exec, say aye.
Aye.
Opposed?
Make a motion to hold the pass?
No, give them time.
I still make a motion. Make a motion about the pass,
On
188.
any discussion? All those in favor of ought to pass? Did you have a question? No. Oh, you're ahead of. All those in favor of ought to pass on 188, say aye.
Aye.
Opposed?
I'll move to consent.
Second?
All those in favor of consent, say aye.
Aye.
I'll
Opposed?
move on to pass on 66.
Second?
Wait, whoa. Who wants to take this
Oh,
out?
yeah, sorry.
I'll take it out.
Yeah, okay, Senator Avard will take it out. Just start.
No, I think for me, it's not enough.
All right, you moved ought to pass on 66.
Seconded?
Senator Avard seconds. Any discussion? All those in favor of ought to pass on, wait, just want to make sure there's only one senator on here.
There is, I checked.
All right. All those in
It's the
favor?
only thing in the bill I read.
Don't say that.
Well, I have to make the appointments, and then
Oh.
everybody gets angry. You
I
know?
love the integrated model.
That's fine.
So
Um,
thank you.
All those in favor of ought to pass on House Bill 66, say aye.
Aye.
Opposed?
Consent?
Consent.
Second.
Third?
And I'd be happy to
All
take it out.
those,
Oh, sorry, consent, we're voting that, sorry.
You're appointed.
all those in favor of consent, say aye.
Aye.
Opposed? And Senator Prentice will be taking it out.
Yeah. Good job.
All right, we still have 6 minutes.
Motion to move.
Oh, yeah, we could do that. Why don't we do 82 first? Do I hear a motion of Oct,
Hold on, now you're faster than me, hang on.
huh?
Move out to pass. 182.
Second.
All right, Senator Whitley moves on to pass, Senator Bradley seconds. Any discussion? This was relative to prompt payments for managed care. Is everyone okay with an ought to pass? Okay. All those in favor, and any discussion? All those in favor of ought to pass, say aye.
Aye.
Opposed?
Move to
Consent.
consent.
Second.
All those in favor of consent, say aye.
Aye.
Opposed?
I can do
And-
that.
Senator Whitley will take that out. Why don't we do, oops, 116.
Move re-refer.
Second.
Any discussion on re-refer? Okay. All those in favor of re-refer, say aye.
Aye.
Opposed?
Consent.
Second.
All those in favor of consent, say aye.
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 Opposed? I'll take this one out. You want to do 95?
You need refer?
Yep.
You
You-
refer?
Second.
Any discussion? I will make it, I do want to make a statement on this one. And I appreciate the amendment that we received yesterday on a very comprehensive bill. However, that doesn't give us enough time to really look at it. So I would highly recommend that the author of the amendment work with the Department of Insurance and get something that we can work with at the end of the fall next year, this year. Please. That being said, where are we? All in favor of re-refer, say aye.
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 Opposed?
Consent?
Consent.
All those in favor of consent, say aye.
Aye.
And I'll take this one out.
Ooh, dear.
Efficient.
The consent of the governed.
Do I hear a motion to move out of,
So move.
move out of consent? Yeah, okay.
Not raising them.
All those in, you can actually get a coffee too if you want. That's awesome.
Are we ready? Oh, sorry. Oh, but you're on the third.
Yeah.
Oh, okay, excellent. You're waiting for 9:30. Thank you very much, Madam Chair, members of the committee. For the record, my name is Dan McGuire. I represent the town of Epsom. The bill in front of you, House Bill 223, is a really simple bill. It takes a particular medication, this one that I have in the box here, and makes an exception for it so that it can be filled in a 90-day cycle rather than a 34-day cycle as current law allows. So this is topical testosterone. So it's for men, typically elderly, including myself, who are low on testosterone, and it's a gel. It's like a hand sanitizer. You rub it on your shoulder or your leg, and it gets absorbed through the skin. It happens to be in the same chemical category as something that can be abused. This is really very gentle. My doctor told me that if you wanted to abuse this, you'd have to fill a bathtub with it and soak in it. And this is a $200 bottle, so it looks like this. It's just a pump bottle that your dose is some number of pumps per day. This bottle lasts about 3 weeks for my particular prescription. So that means I have to, under current law, I have to order it like 15, 16 times a year. That's 15 or 16 copays, et cetera, et cetera. It's a kind of medication that once somebody starts taking it because they have low testosterone, they're just going to take it for the rest of their life. So this bill will save, I estimate, somewhere between 1,000 and 2,000 men in New Hampshire, 10 copays a year or something like that. That's kind of what it's very simple.
Thank you, Representative. Any questions from the committee? Seeing none, thank you.
Thank you very much.
I only have Representative Popovich Mueller supporting, not speaking. Is there anyone here that would like to speak on a House Bill?
I wanted to say my co-sponsor gave you a letter, so you should have that
I
on
ha-
your desk. Yeah. Thank you.
We have it. Oh, yeah. Is there anyone here that would like to speak on House Bill 223 that has not been given the opportunity? With that, I will close the hearing on House Bill 223. Do you want to exec this one?
I might as well move into exec.
Oh, okay. Okay, so Senator Avard moves exec. Was there a second?
Second.
Senator Bradley, seconds. Do I hear a motion?
All in favor?
All in favor of going into an exec, say
Aye.
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 Opposed?
Move ought to pass 23.
Is there a second?
Second. Sorry.
Any discussion? All those in favor of ought to pass on House Bill 223, say aye.
Aye.
Opposed?
Move into consent.
Second.
All those in favor of consent, say aye.
Aye.
Opposed?
Take it out.
Senator Avard will take this one out.
Motion to move out of exec.
Second. All those in favor of moving out of consent, say aye. Aye. Opposed? Okay. We are out of exec. It is 9:45, so we will start the hearing on Senate Bill 500, and Senator Prentice will be introducing the bill. Welcome, Senator Prentice. Long time no see.
All right, Cam, I've managed to get my microphone on and get in the right chair. Good morning, members of Senate HHS. For the record, my name is Suzanne Prentice. I'm a state senator from District 5, representing 15 communities, a large part of Grafton County, part of Sullivan County, and one in Merrimack County, lovely New London, New Hampshire. So I'm here to introduce House Bill 500 on behalf of Representatives Hockin, Phillips, and Murphy. House Bill 500 is a patient advocacy bill allowing providers to prescribe Schedule 2 through 4 drugs via telehealth. This is about advancing the delivery of health care in an oftentimes compassionate and patient convenient manner. It is the logical extension of previous legislation and an emergency order allowing for the establishment of a patient-provider relationship via telehealth. I think as we've all observed, telehealth has grown substantially during the pandemic, with patient status also equaling. We've seen growing positivity around patient satisfaction. This is, and if not, in some cases, it's been seen to be superior to in-person visits. At Dartmouth Hitchcock alone, which is headquartered primarily located in my district, patient visits increased via telehealth from 10 to 12 a day to 2,600 during the pandemic, and it has stayed steady in those high numbers since that time. There are always inpatient visit options available, but this just goes to show what access to healthcare, how access to healthcare has changed, and I think to the better for our patient population. So accessing healthcare, especially specialty care, has become increasingly difficult for many patients. Transportation, work, or childcare obligations, too sick, too fragile, or too fragile or immunocompromised, and making it hard. And sometimes unable to unable to travel to get to where you need to be. So patients will neglect care that they need because of some of these circumstances that I've shared with you. During the pandemic, under the emergency order, providers have been able to prescribe Schedule 2 through 4 drugs without any problems or concerns. And we have some medical professionals that are here today that are going to testify to this. Remarkably, without any precedent, we basically ran a pilot project under an emergency order to take telehealth, which was already available, and push it out to its maximum and see how it removed barriers, raised patient satisfaction. And I think the most important thing is that with these barriers, patients got the care that they needed. So we're up against it. I think it's important to always state that we are up against a deadline with this emergency order being lifted in May. And if we don't do something, these patients could fall to the wayside while we come back at trying to address this issue. So time is of the essence. So just some summary points. This bill will facilitate the medically appropriate care of patients in several clinically appropriate circumstances. Patients suffering at home in palliative care who are too sick, or too fragile, or immunocompromised to travel. Hematology and oncology patients are also similarly too weak or sick to travel and often immunocompromised as well. Adolescents with mental illness like ADHD not wanting to miss a full day or even a part day of school, or their parents who have to work and are not able to take them to an appointment, they would be able to get this access always with parental consent. Postoperative trauma and surgical patients whose pain levels fluctuate, require a change in their medications, but for whom, again, travel is uncomfortable and possibly harmful to their recovery. There are several safeguards that have been put into place with this bill so that this practice is not abused. The standard of care and professional responsibility, so this, state and DEA licensure, a requirement in New Hampshire statute for an in-person visit, and at intervals appropriate for the patient's medical condition and drug, but not less than annually. In New Hampshire, this falls under the New Hampshire Prescription Drug Monitoring Program, and again, minors will be required to have parental consent. Prescribing Schedule 2 through 4 medications via telehealth for medically appropriate patients is simply good compassionate care for families and is enthusiastically endorsed by providers, some of which are here, patients, and families. We saw this come out of House HHS with full support, not a pass, and obviously it's with us because it passed the House, and I think we should follow suit. Thank you for taking my testimony. I'm happy to answer any questions, but I most likely will defer to some of the experts behind me. Thank you.
Any questions from the committee? Hearing none. Thank you. Roger Osman from West Central Behavioral. Welcome.
Good morning. Thank you, Madam Chair and members of the committee. My name is Dr. Roger Osman. I am President and CEO of West Central Behavioral Health. We are one of the 10 community mental health centers in New Hampshire. I'm here today on behalf of the New Hampshire Community Behavioral Health Association to speak in support of House Bill 500. Recently, this committee heard Senate Bill 238, which would expand telehealth prescribing authority for from substance abuse disorder treatment to include mental health, which I testified in support of. The community mental health centers are very much in support of the passage of HB 500, which would give the authority to prescribe via telehealth to other important healthcare arenas. This is very valuable to the psychiatrists and nurse practitioners that work for our organizations. Telehealth is a critical tool for our community mental health centers, which quickly transitioned to telehealth as our nearly exclusive means in the early stages of the pandemic. And as Senator Prentice said earlier, it threw us into a service that was pre-existing for us, but rarely, really adopted. But it allowed the organizations to recognize the greater flexibility, including access. And as Senator Prentice mentioned, particularly for us, I think a lot of this is child interventions, where parents may be working, children are in school, there may be limited evening appointments, and then greater flexibility when they can do that and avoid missing school time. At West Central, we see firsthand these issues. Given our relatively rural part of the community in Grafton and Sullivan counties, we see how sometimes individuals that have transportation difficulties, this can become a life-saving component to being able to access routine care. And as was mentioned, this does not preclude the expectation of periodic in-person. So as you may recall from Senate Bill 238, my colleague, Dr. Mary Lou Tyner, who is the medical director of Nashua, Greater Nashua Mental Health Center, she had reported that 50% of the patients that she personally sees receive prescriptions to some degree under the controlled substances that this would impact. That includes issues of ADHD, anxiety, insomnia, and things of that nature. And she had testified to this committee that if that bill had failed, that it would have strict limitations on the ability to maintain quality access, quality care, and flexible offerings to our patients. And we believe the same is true for House Bill 500. So I really encourage the committee to consider passage for this. Thank you.
Thank you. Any questions from the committee? Senator Bradley.
Thank you very much, Madam Chair. So I just have a couple of questions. There was some question after the hearing on Senate Bill 238 about in-person requirements for mental health practitioners. So could you clarify, because I think we were left with the understanding that for behavioral health, there had to be a in-person visit every 3 months. Is that correct?
As part of 238 or
No.
beyond?
It was not as part of 238, but it was, as I recall, it was part of the testimony or what we were told afterwards. Because, and I'll get to my concern in just a moment, but if you could clarify that, that'd be helpful.
I'm not aware of anything about 3 months. Senator Prentice actually mentioned earlier about the once a year. It's very common that the first appointment with a patient will be in person. And then after that, again, it'll be determined based on the clinical issue, the medications, the needs, how frequently would occur after that. But typically, I think in the profession and I would defer to, I know there's a physician or two that may be speaking later, any DEA requirements that require, but I've typically heard the 1 year is the minimum.
Okay, so then my second question, where in either your rules as practicing physicians or in statute is it clear that parental consent must be obtained for anyone under 18 in order to be prescribed 2 through 4 schedule?
I can't speak off the top of my head about the specific rule or RSA, but I know that New Hampshire does not have any exception to individuals below the age of 18 for age of consent. Other states, for example, I come from Pennsylvania 4 years ago, and they allowed individuals that were 14 and older to consent independent of their parents. My understanding is New Hampshire does not have that. Therefore, whether it's consent for treatment of psychotherapy, case management, as well as medications, that the law requires that parents are involved in those. So my understanding is whether it was 238 or House Bill 500, that it was not included as a reference because it's already existing requirement.
Okay, well, I'm glad to hear that you think it's there. I'm not so sure, but
Okay.
which
I
is
wish
why
I wish I
Senator
could speak
Prentice,
specifically to that reference.
Okay, maybe somebody else can answer that question.
Okay.
Thank you.
Any other questions from the committee? Seeing none, thank you, Doctor. Matthew Hood and Amelia, you want to be up there together?
With your permission, Madam
Yep.
Chair? Thank you.
Madam Chair, members of the committee, for the record, my name is Matthew Hood. I'm Vice President of Government Relations at Dartmouth Health. And with me is Dr. Amelia Cullinan. Thank you for letting us come up together. I think Senator Prentice did a terrific job of outlining the history, so I won't belabor the point about the evolution of 329, but essentially bring you to where we are today, which is today, prescribers can only prescribe via telehealth in New Hampshire for the treatment of substance use disorder. We've recognized as a result of the state of emergency and Executive Order number 8, in addition to the public health emergency and the DEA flexibilities that were allowed during the public health emergency, that there were many more applications than substance use disorder for telehealth prescribing. You've heard Senator Prentice's bill with respect to adding mental health to that category. And what House Bill 500 does is it removes any limit with respect to practice area. Dr. Cullinan will speak to the utilization in palliative care. You've already heard Roger Osmond speak to behavioral health applications, ADHD for adolescents and children. There's cancer care that's appropriate for this. There's post-acute surgical procedures when people have increased pain, et cetera. So what I'd like to do is try to address some of Senator Bradley's questions if I can. The DEA, a prescriber has to follow both state and federal law. Whichever one is more strict is the one you have to follow. So the DEA has proposed rules for telehealth prescribing in all contexts. I want to emphasize that they didn't put a limitation on practice areas for prescribing via telehealth. They do require an in-person visit prior to prescribing. So that's one of the safeguards. Whether or not it's in New Hampshire law, a prescriber has to follow that per the DEA. That's correct. They're proposed rules. Very unlikely that the in-person requirement will be waived. No one has an objection to the in-person requirement being put in New Hampshire law if that's something that the legislature is inclined to do. What the statute does, 329, is specifically provide that an in-person visit will be conducted as appropriate for the patient or the condition, but no less than once a year thereafter. So that's already in New Hampshire law. So you have the front end but with the DEA's requirement and the back end and the in-process covered by New Hampshire statute. Telehealth is a mode of healthcare delivery. We don't treat it any differently than an in-person visit. For minors, we get a consent to treat at the outset of every visit between a parent, from the parents. And that's updated annually. So to answer your question about is there a statute that requires parental consent, I think it's by the implication of the inverse, Senator. What do I mean by that? There are only a few exceptions in New Hampshire or federal law that require confidentiality in that context, in the context of abuse and neglect, STDs. You know this list better than I do, Senator. But in all, so the inverse of that is that every other requires sharing of that information. There's no confidentiality in that space. So with that, I think what's much more impactful than my recitation of the trajectory is Dr. Cullinan's clinical experience with patients and the benefits that they've seen during the course of the public health emergency and the state of emergency order.
Good morning. Thank you for hearing my testimony. My name is Amelia Cullinan. I'm a palliative care physician. I direct the outpatient palliative care clinic at DH. And I'll tell you a little bit about what palliative care is. There's a lot of misconceptions about it. We take care of patients who have serious or life-limiting illnesses, usually with months to years to live, while they're concurrently receiving care to prolong their lives and to treat their diseases. Our job is to try to help them live as well as they can for the time that they have left, to support them and their families, both emotionally and physically, with the physical symptoms that can come along with a serious illness. With the public health emergency, it allowed us to expand into using telehealth in a way we never had been able to use it before. We went to a model of almost 100% telehealth during the pandemic, but at this point, still 70% of our visits are via telehealth by patient choice. So the flexibility to prescribe by telehealth helps patients like a patient of mine who has an ALS-like syndrome. He's homebound. He has profound weakness of his arms, legs, can barely speak, depends on something like a CPAP device to rest his breathing muscles. So as you can imagine, getting to the hospital for an in-person visit, it actually requires 3 people and a lift to get him into his motorized wheelchair, and that's just out of bed and on the way to the car, right? So that patient has severe shortness of breath, and he can use his CPAP machine, but it's not always enough. I need to prescribe him morphine for shortness of breath, but I would not be permitted to do so because I'm not able to see him in person. So that creates suffering for him and for his wife and for his children. Other patients with cancer whom I care for, I may have been treating them for coping with illness and planning for future needs, and then they develop pain from, say, the cancer has spread to a bone somewhere. Maybe it's not responding to over-the-counter medication anymore, Tylenol, ibuprofen. I need to be able to prescribe opioids to that patient. If I force them to wait to receive opioids until the 2, maybe 3 weeks until I can get them in to be seen, they're suffering during that time. Or maybe they're ending up in an emergency room, which, as we all know, are overwhelmed, right? So this is both making sure that patients don't suffer and that we're equitably using our resources. One last example, we take care of patients who have been traumatized by being in the healthcare system, who have severe mental health disorders, claustrophobia, PTSD. I need to be able to prescribe them medication without forcing them to come into a place that is frankly traumatizing. I need to be able to give them medication to palliate those symptoms without demanding that they come into a place that's upsetting. So I just wanted to highlight 2 other areas that I think are important. One is the idea of equity, which has already been spoken to, but as you know, this is a rural state. I have patients coming to see me, or I am seeing them in their homes from places as far away as Berlin, all the way down here in the southern region. Gas is expensive, money is tight, even having a car or someone to drive it. Those are all barriers to being able to come in. And so this allows access to healthcare for people who are in the most vulnerable place in their lives. And the last piece I would say is that part of my job as a palliative care physician is to make sure that I deliver care that is consistent with each patient's goals and values. New Hampshire is a state that prioritizes patient autonomy. I would say that giving the flexibility to providers to be able to deliver the care to patients when and where they need it is emphasizing that patient right to access to care. Thank you very much, and I'm happy to answer any questions.
Any questions from the committee? No? Really? All right. Sure.
I just wanted to add a couple of things in conclusion for support for HB 500, which is, first of all, I wanted to thank you for your work over the course of the previous sessions with respect to recognizing the benefits of telehealth, the need for flexibility in terms of access challenges because of workforce and otherwise. Telehealth is a crucial tool in that space. Recognize that the House Health and Human Services Committee, Representatives Merchant and Leon worked together on the amendment that you have before you to get a 20-0 vote out of the House committee and on the consent calendar in the House. Recognize that this amendment would make us consistent with the laws of the surrounding states, Massachusetts, Maine, Vermont, in terms of telehealth prescribing. In order for us to benefit from the flexibilities that the federal law/DEA allow, state law has to allow that flexibility too. Otherwise, we won't be able to capitalize it because, again, you need to be adherent to the strictest requirements. And the safeguards that are in place, whether it's for opioid prescribing or otherwise in an in-person context, exist in a telehealth context as well. I'll submit my written testimony, which has a list of those safeguards, so you have that for your consideration and deliberations. Thank you.
And since you're an attorney, if you could cite the citation that requires parental consent for prescribing, that would be helpful. I'm not sure it exists, but
I will certainly double check that question, Senator, and acknowledging that the answer might be, again, it's what's implied, because the only exceptions that exist pertain to the three categories that you so well articulated.
then my view would be belts and suspenders probably is not a bad idea, and I think you'd probably agree with that.
I will look into that question for you,
Okay, all right.
Senator.
Any other questions from the committee? Seeing none, thank you. Laura Condon. And right now, she is our last speaker. If anyone is interested in following Laura, feel free to let us know. Welcome.
Good morning. My name is Laura Condon. I'm from Bedford, New Hampshire, and I'm here to oppose House Bill 500 relative to prescribing opioids via telehealth medicine. This bill, as we've heard, is similar to Senate Bill 238, and I testified in opposition to that with concerns about this really being a free-for-all for these scheduled drugs for children. This bill will permit physicians and nurses to prescribe Schedule II through Schedule IV drugs via telehealth, drugs that are considered dangerous by the U.S. Drug Enforcement Administration. This bill ignores the fact that psychotropic drugs handed out like candy are a problem and calls for the temporary practice of using telehealth to hand out these drugs to be made permanent. This bill would allow poorly supervised access to endless doses of mind-altering prescription drugs to children. When these drugs are handed out like candy, multiple drugs with increasing and decreasing doses put children are put at risk. Are these drugs contributing to school shootings? Are these drugs contributing to teen suicides? How would we know? We must prevent these easy access, poorly supervised handing out of psychotropic drugs via telehealth, especially to children. There is no evidence that what was done on an emergency basis during COVID should become a permanent practice. These are federally controlled and scheduled drugs for very good reason. Evidence is that these Schedule 2 through 4 prescription drugs can be very dangerous, even deadly, to the person prescribed the drug, their family members, schoolmates, and coworkers. People who seek these drugs should be carefully evaluated and monitored in person. This is not the time and place for telehealth to get cocktails of these drugs on a cell phone call or a text message. One doctor visit a year and no requirement for in-person evaluation for additional drugs or changes in dosages are dangerous practices and bad medicine, especially for children. And we should remember that parents are not doctors. And while they may be given consent, they're relying on professionals who've properly evaluated the children. And these children, to be properly evaluated, need to be seen by those professionals. The scheduled 2 through 4 controlled drugs are such that the Schedule 2 controlled substances have a high potential for abuse, which may lead, and this is from the DEA, which may lead to severe psychological or physical dependence and includes such drugs as oxycodone, fentanyl, morphine, amphetamines such as Adderall, methamphetamines, methylphenidate, and phenobarbital. For your information, phenobarbital is a sedative that slows the activity of the brain and nervous system and is commonly used to euthanize pets. Since 2010, 14 states have used phenobarbital in state executions. Schedule 3 controlled substances include substances that also have potential for abuse. They may lead to psychological or physical dependence. This class of drugs includes anabolic steroids, and this artificial steroid is now commonly used in transgender males. The Schedule 4 controlled drugs also are at risk for abuse and can and do cause overdose and death. Examples include Xanax, Klonopin, Valium, and Ativan, and others. So just how dangerous are these prescription mind-altering drugs? Well, they can be deadly, in fact. And this speaks to the failure of our neighboring state, so we should be cautious about doing what neighboring states do. Because in fact, in January of 2023 in Duxbury, Mass., Lindsay Clancy strangled her 3 children to death and then cut her wrists and neck and jumped from a window, resulting in severe spinal cord injury. This 32-year-old mother had been prescribed a cocktail of 13 psychotropic medications to treat her mental health. This woman had been given this cocktail of drugs that resulted in homicidal and suicidal ideations and actions. Her dosages and prescriptions have been repeatedly altered by doctors with inadequate evaluation, supervision, and monitoring. This woman was not a demon prior to her being prescribed these drugs. She was a labor and delivery nurse who was very caring for her children, her family, her friends, and her patients. I caution us to follow the path of doing what other states do simply because they are doing it. The risk of suicide in children and adolescents being treated with antidepressants is well-established science. Years ago, the FDA directed manufacturers of all antidepressant drugs to revise the relabeling for their products to include a black box warning and expanded this warning to alert healthcare providers to an increased risk of suicidality. Pediatric patients being treated with antidepressants for any indication should be closely blurred for clinical worsening as well as agitation, irritability, suicidality, and unusual changes of behavior, especially during the initial few months of a course of drug therapy or at times of dosage changes, either increase or decreases. Such monitoring requires face-to-face, in-person interactions and observations that cannot be done via telehealth. For heaven's sakes, we've all been on the Zoom meetings over the last several years. We know that those sort of, and telehealth doesn't even require video, it could be on a phone call. We all know that those interactions are inadequate compared to in-person meetings. During COVID, when telehealth was used to prescribe these drugs to teenagers, there was actually a 22.3% spike in ER trips for suicide attempts by teenagers. So this is during the trial period of telehealth. These drugs are not candy and should not be dispensed by telehealth as if they were. I was shocked to hear testimony in the House on this bill that expressed excitement that children with ADHD would be able to get these drugs without leaving school, and parents won't even have to leave work. It's horrifying. This is not how mind-altering drugs should be given to children. I urge you to oppose House Bill 500 and recommend it inexpedient to legislate. At the very least, I urge you to amend this bill to protect children from aggressive, dangerous, and often unnecessary drugging by restricting this type of telehealth to adults only. Thank you very much, and I'd be happy to take any questions. And may I add, I appreciate very much, Senator Bradley, your concern relative to this bill and also 238 and how it would impact children. That's very much appreciated.
Any questions from the committee? Seeing none, thank you.
Thank you.
As I said, Laura was the last speaker. Is there anyone that would like to speak on House Bill 500? If not, I will close the hearing on House Bill 500, and we will not exec this today.
Motion to adjourn?
I'll second that motion to adjourn. All in favor, say aye. Opposed? Okay. We are adjourned.